Well, thank you so much, Dr. Davis. I'm Josh Sharpstein, and I am the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health. And we're here for the next panel, which I'm delighted to introduce and get started on. I see my fellow panelists here. And just to set the stage, I am going back to that great last presentation about whole person health. There was a picture of a tree. And the tree talked about all the different contributors to health for an individual. We're kind of talking about the global climate here. We're talking about the large scale policy change that makes a lot of things possible at the individual tree level. And we have three amazing people to join the conversation about this. First, we will hear from Donna Kinzer, who is a principal at DK Healthcare Consulting. I think DK might stand for Donna Kinzer. She was the director of the Health Services Cost Review Commission when Maryland implemented its innovative model to do global budgeting for all hospitals and all payers in the state of Maryland. And Donna is really known as the person who understands that model, how it works, its challenges, and its successes better than anyone. So really great to have her here. Then I'll turn to Ina Bacchus, who is from the state of Vermont Agency of Human Services. She's the director of health reform, and she is deeply involved in the all-payer ACO effort, where Vermont is really doing some very innovative things at the state level, just like Donna will talk about Maryland at the Maryland level. Ina will talk about Vermont at the Vermont level, and how policies align not just for cost control, but also for better health. And then we're going to talk to Cindy Mann, who is a partner at Manat Health and known also for her tremendous work in the federal government as the director of the Medicaid program. And Cindy is going to talk both about how the large federal forces in healthcare, Medicare, and Medicaid can support massive environmental state level intervention, but also talk about how these programs can be innovative partners to other sectors for even more global kinds of reform. So we're not going to be at the leaf level, we're not going to be at the tree level, we're going to be at the environmental level, I think, and it's going to be a nice complement to some of the other presentations so far. So maybe we'll start with you, Donna. Why don't you just set the stage, if you could, for Maryland, what is going on in Maryland, and if you could emphasize the parts of the Maryland model that really align with the health of people in Maryland.
Well, thank you. I appreciate the opportunity to be here today, and I'm looking forward to the discussion afterwards. I'm going to start with some brief level setting, and so that folks can hopefully get on the same page about what the Maryland model is. I think my slides disappeared. At least I'm not seeing them, but I'll start without them, and maybe we'll get them up, but if not, we'll go without them. Just to level set, the Maryland rate setting has been rate setting for hospitals since the 70s on an all-payer basis, until 2014, that rate setting was a fee-for-service basis. And the rates that are set are paid by all payers. It's unique. Medicare, Medicaid, all the commercial payers pay the rates that are set by the commission. And that system worked to contain cost until sometime after 2000, when the volumes of services began to grow, especially lower intensity outpatient volumes that began to undermine the cost containment approach that the model had set into place. And under Dr. Sharfstein's leadership as Secretary of Health, in 2014, Maryland shifted away from that fee-for-service model to paying hospitals based on global revenues. And under the global revenue system, the amount that a hospital is able to earn is set at the beginning of the year. So it's preset inpatient and outpatient allowed charges for the year, or allowed revenue for the year. And this new system, which moved away from a volume-based payment, incentivized reducing preventable admissions, as well as improving outcomes, because strong outcomes payments were built into the payment model for the hospitals. And that model proceeded for 5 years until the end of 2018, and it was replaced in 2019 by a model that moves beyond hospitals to really encompass the entire delivery system. Just a few quick points about the results from the first 5 years before moving on to describing the next 10 years. The model was able to save nearly $1 billion for the Medicare program, as well as keeping hospital growth rates down for all payers. And in terms of focusing on people and persons in the system, at the beginning of the model, Maryland was one of the worst states on the Medicare readmissions. By the end of the 5 years, the readmissions had dropped below the national average. And also of interest in looking at the results from the model, there was a tremendous focus on chronic conditions and high needs patients. And that showed up in the results because the dually eligible, the disabled, and individuals with multiple chronic conditions had almost double the result in terms of reductions of readmissions and preventable admissions as the general population. But moving on to talking about the model as the state moved to the next slide. As the state moved beyond the hospital payment model, the next phase of the model is focused on not only the hospitals, but on really the entire delivery system through care redesign programs. And I should have put the Maryland Primary Care Program first, because it was always envisioned to be a cornerstone of the model. And that the Maryland Primary Care Program was launched, which focuses on the putting resources in the practices for chronic care, mental health, and focuses on prevention. And the final pillar of the new model is really enhancing the focus on outcomes to move away from just hospital quality outcomes to the population health outcomes. At the bottom, and I'm going to get into that a little bit more in a few minutes. In addition to these pillars, I just want to focus on the infrastructure piece of this, which is the Health Information Exchange, CRISP, at the bottom of this chart, that really is critical to the success of the model across all of the pillars, and was essential to launching the Maryland Primary Care Program. The Health Information Exchange is statewide with extremely well-developed infrastructure, master person index for virtually everyone in the state. And it is supported by deep data resources, including real-time admission, discharge, and transfer, outpatient encounter real-time information plus claims data to for all of the Medicare enrollees and for all payer hospital enrollees. So it's a very rich environment. And now I just want to briefly talk about the, moving on to the next slide. I want to briefly talk about the shift in focus to population health. In the new model, there are 3 domains of focus in terms of the population health outcomes. The first is continues to focus on improving hospital outcomes. The second on ensuring that the transformation process actually happens across the system. That is one thing that we certainly found was needed a lot of prodding along the way. And the third is related to the what we traditionally would think about as population health. In the hospital domain, there is a focus on reducing avoidable hospital admissions, particularly the prevention quality indicators or the admissions for ambulatory sensitive conditions, as well as disparity reduction targets for readmissions. The second domain is focused on making sure that transformation process happens across the system, as well as payment transformation. And then finally, in the population health area, the focus is on reducing diabetes, opioid use, and also focused on maternal health and child health in terms of asthma. There are targets for each and every one of these domains, and the targets are being built into the payment models in terms of outcomes-based payment to the maximum extent possible. They're being built in across the delivery system so that we're actually trying to put payments in for each of those pillars that relate to health outcomes. And I think I just to wrap this up, and I'm will drop off the slide here. I just wanted to talk briefly about how this system played out in the COVID world in terms of the primary care piece in particular. We used the primary care organization and the data-driven approach that built the primary care model. We used that infrastructure to support primary care physicians during COVID with webinars, with updates, testing strategies, where to get your PPE equipment, how to use it. Also a telehealth platform for those who didn't have one through their system or practice, which actually brought about 1/3 of the physicians into the state telehealth platform. And then information to the practices about the high needs patients who were COVID vulnerable and a dashboard. And the results of that intervention is that the individuals in the Maryland Primary Care Program, which is about 300,000 enrollees, were being served under that program. They had a lower incidence of COVID, lower death rates, and lower ICU utilization as we looked and compared that to a control group that was matched to the beneficiaries in the program. So that was how it worked in action, and that is the same way that the program works on a day-to-day basis. But that kind of brings it alive in the COVID environment. So
thank you.
Thank you very much.
Thanks, Donna. And just to follow up real quickly on a couple key points. I think I know the answer to this question, but could you estimate the percentage of people in Maryland whose care is affected by this model that you're talking about?
About the entire model?
The entire model. What percentage of people in Maryland, if they get sick, have their care affected by this model?
If they get sick and go to the hospital, I say it's 100%. And in the primary care mode, we're looking at more than 50% of the Marylanders really being in a practice that is in the transformed environment. But
Got it. So
yeah,
yeah,
so
I was just making the point, this is not for a specific provider, a specific ACO. This is the entire state with a different set of incentives, with different way of paying, particularly for hospital care that can kind of, create the environment for different specific innovations like the ones that you talked about for COVID. And I got the point that there's a big focus now on diabetes and asthma and maternal health and overdose. And just very quickly, I mean, how do you see the statewide model, creating motivation and alignment by all the different people in healthcare to move in that direction? What's the key to that connection? The state is incentivized in a certain way, and how does that kind of dribble down? How does that interact with a provider being able to do things differently?
well, I think because everybody is working off of the same incentive system, and those incentives are being driven down to the provider level through payment model changes. But it's not really just about the incentives. It's really about the providers having a sense of what they're supposed to be doing and what the vision is for changing care. And it's also about the data infrastructure in terms of making sure that the providers have the information that they need to know who the high-risk patients are and to know whether they're being effective in what the results are of the interventions that they have, and that those results are being delivered. I mean, literally on a monthly basis. There's information going out to the hospitals and to the practices to show how they're doing and what they need to do better. And so,
Thank you.
yes.
No, that's great. I appreciate that.